So, talk about the elbow. Yes. 3 bones of the humerus, or the elbow, humerus, radius, ulna. Tomorrow, let's have a quiz on that. What do you think? 3 bones of the elbow, the humerus, radius, and ulna. You have ligament to the elbow, which is your ulnar collateral. Collateral. You've heard collateral before, right? Where? Exactly. Where's it on? Yes, the sides. Exactly. I know. So you're going to have an ulnar collateral, a radial collateral, and an annular ligament. All right. All right. No, they're not. They're not cruciates. Okay. You don't. They're not across in the middle like in a knee. But there are those that keep it from sliding open this way or that way. Now, what we got to understand is that they get their name, anatomical position. The ulna is on the outside, or actually in the anatomical position, it's right here on the inside. But it's your defensive bone. If you got defensive wounds, you're getting hit in the ulna. The radius is this one. So the radius, and we'll get through this quickly. All right. Let me see if we've got a picture of an elbow. No. No, we did have one more. That one? That's a dislocated elbow. It's not really. All right. That one wants to be close. All right. The radius, and we'll get this great big long one here. Here we are, elbow. Hi. It's close. Not quite. Yeah, pretty close. So, all right. The ulna, okay, comes down and it's right here. That's where you get the bump, the styloid process. The other one is on this side, and as it comes up, you can see it has a round circle. Well, it has a circle because when you rotate it, it actually rotates with your supination and pronation. Supination, make to hold your soup. Pronate. Pour it out. Oh. That works, doesn't it? Okay. So here it is. It's way up here on this side. It comes way up. Follow the bone. It comes clear across. So it actually rotates. That's why they call it the radius. See, you find ways of learning. It's amazing. What? If you double join it, yeah. I mean, they go backwards usually. Yes. Look at yours. Yours are double jointed is what's called MDI, multi-directional instability. All right. Great for athletes, and it's terrible for athletes. But that's not what we're doing. It's considered to be a complex joint because of the humerus articulates with the radius and the ulna. Flexion and extension of the forearm are carried out in the sagittal plane, and supination and pronation in the transverse plane. Comprende? All right. Contusions. Certainly you can get contusions. Not a whole lot of padding in the elbow unless you're overly padded everywhere. So, yes. If you're a big bone person. All right. So, because of the lack of padding, the elbow is vulnerable to injury. Contusion to the elbow may cause rapid swelling, and after an irritation of the olecranon bursa or the synovial membrane. So here's your olecranon fossa and your olecranon process. I don't know if we can actually see it here. The olecranon fossa is down underneath here on the humerus. There's like a little spoon part, and that's where your elbow comes up and meets. So where we see like this getting irritated, you start, yes, you start seeing pictures, all right? Instead of them using muscular and soft tendon and soft tissue to slow their momentum down as they pitch, they use their bony structure to stop their arm at the elbow. Obviously, that's going to start irritating. All right? So you've got to learn to let the motion go through and dissipate that way as opposed to snap and go through. But some pitchers don't ever figure that out. And they're short-lived as far as being pitchers. The olecranon, or the bursa back here, we talked about bursas before, and they have the little, they're there to squirt WD-40, not really, but synovial fluid to make sure that everything has less friction. But you hit it right here, all right? So I'll find a picture of one tomorrow that will say, Joe Montana, he had this. And so it looks like half a tennis ball that comes up, or this, well, maybe a golf ball comes up on it. And that was this guy I was talking to one of the classes about that had a bursa that got all inflamed. And he came in after practice, and we were going to drain it because he was having a problem with it for about a week or so. And so we put ice on it, and that stuff turns into like jello. We couldn't aspirate it. We couldn't pull it out, drain it, because we tried to the doctor pulled it out, and nothing came. He let loose, and it went whoosh, right back over. So that stuff is you need it to be warm if you're going to try and get rid of the olecranon bursa fluid. So either with a bruise or with a bursitis, treat immediately with cold and pressure for at least 24 hours. And if the injury is severe, the athlete should be referred to a physician to determine whether or not there's a fracture. Now, you guys don't see us use this all the time, but these are great. These are great. This tubular bandage, okay? And it comes in a great big roll, and that's probably about half used. And so you cut off, oh, what is that, a foot? Maybe a foot and a half. So, right. But what I'm able to do is I can put it on. If that's good enough, great. If not, if I want a little more compression, then I can double it back over. And then, especially with a bursitis problem, if you got bursa, you can have them wear that for 24 hours, as long as they've got capillary refill and they've got plenty of circulation below it. You're good to go. It works better than an ACE wrap because the ACE wrap's going to unwind and all of that fun stuff. This is a whole lot easier. The compression sleeve, exactly. All right, so have them come in daily to make sure that you're checking to make. And now also you got to know that the number one sign if you don't have deformity, the number one sign of a fracture is immediate swelling. So, are you sure it's swollen, or are you sure it's a bursa? That's where knowing where these little olecranon bursas lay will help you make that decision. The olecranon bursa is lying between the end of the olecranon process and the skin. It's most frequently injured bursa in the elbow. So, see your hand here. All right, the olecranon fossa, and a fossa is a divot. So it's really tough to see, but it's that little spoon right there. That's part of the humerus. The olecranon process is the part that fits into it. So this part of this bone is going to fit right into that, and that actually has a bony stop. So if you ever like pop your elbows, yeah, the bones are stopping it. So it sits right over here. There you go. All those things that you hear, like your knuckles, your knees, your ankles, it's just synovial gases being released out of the joint. It's because it's just an old wives' tale. Probably some mama didn't like it, and then so she told her one kid, who then told everybody in school, who then told all of their family, who then it spread across the world. All right. The inflamed bursa produces pain, severe swelling, and point tenderness. All right. Treat with cold compress for at least an hour, and then aspiration to hasten healing with persistent swelling. But don't ice it before you aspirate. Aspiration means we put a needle in and we pull the fluid out. Right? Wear a compression sleeve during the day. All right. Strains to the elbow because you got muscles that are all coming across that joint. Okay? You got this one. What's this one? And the one on the back? Exactly. They're going across the joint because they make the joint move. So strains can occur to the biceps, triceps, the brachialis muscles, and these muscles should be tested through active and resistant range of motion. So, no, you. Come. So, pull back, pull against there, pull back. So we're testing to see what we've got here. Now, take it, turn your hand forward, push, push. All right, testing the triceps. All right, don't let me turn this way. All right. So here we go, and then the other one would be, don't let me go that way. And so now what we're doing is, now we can also do another one, to wrist break. Don't let me pull this down. Oh, you poor thing. So now we've gone from here to there, and 5 easy steps. So signs include tenderness, especially during activity, and resistance range of motion, which is what she was doing, and point tenderness in the muscle, the tendon, or the lower part of the muscle belly. Treat with price, and if it's bad enough, use a sling. Follow up with ice, ultrasound, rehab exercises, and if it's persistent, use an X-ray to rule out a fracture. Okay? You only know. Holy smoke! Medial epicondylitis. All right, pitcher's elbow or little league elbow. Also, like golfer's elbow. If you got a bad golfer, they'll get medial epicondylitis also. All right. So here's the medial epicondyle. The medial epicondyle of, yes, an epicondyle is a, well, no, it's not circular, but it's a protruding of the bone. So it's with these attachments. See it on the back of this elbow right here, part of the humerus, but it's where these attach to the humerus. So the medial epicondyle. So they say if you're playing golf that you're supposed to bring your wrist or your elbow to your side, and then you're rotating the club head. All right? So you come down and rotate. You're doing this wrong, or you haven't been playing, you keep hitting the ball fat, then this part starts to hurt. And it hurts pretty good. It's smart. All right? It's as bad as patellar tendonitis. You get a pitcher who is throwing a lot of breaking balls, or a pitcher who's using the elbow bony structure to stop his motion. You're going to end up with medial epicondylitis. Pain over the medial epicondyle of the humerus that can be produced during forceful wrist flexion or extension. Treat with rest. Remember when we talked about tendonitis, you're getting micro tears turning into macro tears. So obviously we've got to take whatever it is that's causing the micro tears and stop it, or you're going to keep having more and more and more and more tears, causing the tendonitis. All right, you can start with cold therapy, but you've got to be careful. All right, come. We're not there yet. All right, so if I look at her arm right here, I can put my hand right here. Pull your sleeve up. All right, see that right there? You can see the medial epicondyle right here. All right, if I go right beneath the medial epicondyle. Oh my God. Did you feel that in your fingers? No. You didn't? Well, let's do it again. All right, right there is your nerve. So when you're icing, thank you so much. All right. Yes, technically it's your funny bone. It's not a bone, it's a nerve. All right? You need to know where that is so that when you grow up, you find the man of your dreams, and you all have children, right? You all have children.
No, it's right there, right?
So once you have children and you're in the mall and they're not paying attention, instead of grabbing their ear, you can grab their arm and just pluck that nerve like it's a guitar string, and you will have their attention for probably 5 minutes at least. Now, be careful because they might hate you for those 5 minutes. All right? So when you're icing that medial epicondyle, it's very important that you tell them, see, here's the nerve right here. It's very important that you tell them that.
Is that yellow thing?
Yes.
Is that really how thick they are?
Yeah, probably.
I don't like that.
Probably.
They're not squishy.
I know that I have seen the spinal cord of a coyote.
Coyote?
Yes. It is about that thick on a small dog.
A spinal
The
nerve?
spinal cord.
Oh.
All right? It's inside the vertebra. It's probably about that round. So, well, no, it's all covered up. It's all covered up with vertebra. So we can see where this nerve comes here, right? So if I put ice on this nerve, I can palsy that nerve. I can actually do damage to it, and I can do actual lifelong damage to it if I leave it on long enough. So it's important that if you're icing this, that you try and keep it off of the nerve. So that means I go from here to here with the ice, great. If I'm going here and here, but as long as I'm staying out of that groove, staying off of the nerve. You also have to tell your athlete, tell them, hey, look, if this hurts, you're better off with the swelling than what you are with nerve problems. Take it off. So I always tell them no more than 15 minutes. No more. Take it off and then go. So treat with anti-inflammatory drugs. You can also get those either prescribed or use ibuprofen. All right. A brace may be applied just below the end of the elbow. And you've seen those with like old timers where they have a brace that just wraps around their arm. No, it's not much of a brace. It's just a band that wraps around. You know, like the band that you see for patellar tendonitis? Or if we take the pre-wrap and wrap it underneath their kneecap and then roll it up? You can't. So, yep. All right. Now, you didn't go through what?
This one and this one.
Oh, did we miss those? Okay, well, let's go to lateral epicondylitis then. Oh, we didn't even do elbow sprains. We just did strains. Somehow it got over there. Elbow sprains. Sprains are injuries to your
Oh. Your ligament.
ligaments. Your muscles to your, and ligaments hold what to what?
Bone to bone. No,
Bone to bone. Exactly. So, all right. I don't know if this is actually showing much of a ligament on here. No, not really. Um, so, usually caused by hyperextension or valgus forces. Somebody falls on it. When they fall, you usually see them and they end up with their elbow going this way. All right? I hadn't used you. You have to come. Okay? Now, so somebody will come in and they'll say, I've hyperextended my elbow. All right. So the bicep itself is going to be hyperextended and sore. So if I just get it even to here, this is already sore. But then what I'm going to do is I'm going to have them pronate or supinate their hand so it's up. And then relax your shoulder. Relax your shoulder. No, it's not. There we go. There it is. And I'm doing this. Okay? Bring it out, and it comes to a stop. Now, if she's got a sprain right there, one, the stop's not going to be as good as what this is. And two, the other part about it is it's going to light her up. She is not going to like me at all because that ligament got a sprain, and so now I'm pulling it even more, and it hurts. So pain is point tenderness over the MC or UCL, medial collateral, or ulnar collateral ligament. Where's your dealie? Okay? You can remember which one's your ulna. Your ulna is out here on your pinky side. So we follow the pinky side. Once we have them rotated up, because her thumb was out here, now he won't change. Rotates it out, and the UCL is your MCL, your medial collateral.
So wait, how do you?
Just yeah, down to the side. So treat with cold pressure, 24 to 48 hours. A sling might help. If they're playing football, you can tape them in a hyperextension tape job, which is to keep them from getting to full extension, and that will help also prevent the elbow from being out here and getting that force, that valgus force.
So that brace thing that Luke had on, like what was that for?
Mm-hmm. It's what he had. He had a UCL.
What was that for?
He had a UCL. Mm-hmm. He had a UCL sprain or a ulnar collateral ligament sprain. That's what J.J. Watt wears to protect. So this is him doing the UCL test. That picture, that athlete doesn't look like he's too happy. Lateral epicondylitis. Okay, we just talked about medial, even though it wasn't in this order. Lateral epicondylitis is out here. So if I'm doing something repetitive, okay, that is this way, over and over and over, this is going to get irritated. Now, let's take this, all right? Let's take this, and let's take the shoulder and do the same thing. So it's got a common name of tennis elbow. Yeah. So lateral epicondylitis is like tennis elbow. Who's up now? I think you look great. Come on. All right. Huh?
What?
Oh. All right. I need you to do this on yourself. Okay? Feel that right there?
Yeah.
Feel that? That's where you get, that's the tendon that gets tendonitis. Come.
Does it go back and forth?
Yes.
Oh my god.
What? Get over here. All right, maybe she's got some from skiing. Maybe she got some lateral epicondylitis. Think about that, though. If you think about that, you certainly can because you're constantly bringing the poles up and putting them down.
No, not.
Or pushing,
I was like sticking herself all the way down.
or pushing yourself off the floor. That is actually, this here, when you find it right there, that's actually one of the treatments that you can use for lateral epicondylitis, but you're going to push a whole lot harder. And it hurts. The therapy actually really hurts quite a bit. So the the treatment is a deep transverse massage on that. It hurts, but when you're done with it, what it's done is it increases blood flow to help bring all the goody stuff in to try and help heal it. Uh, I think one of the absolute best treatments is ultrasound, and if you can use it with phonophoresis, where the pharmacist will make up a paste of hydrocortisone, and you put the cortisone on the skin. It rubs the lotion on its skin. You don't even know that, do you? You guys got to start watching Joe Dirt. But yeah, okay. Well, and then the sound waves pushes the cortisone from the paste into the tissue, and so that helps quite a bit too. Also, you're doing exercises here, doing exercises here. You're stretching. You're stretching. You can pronate and supinate. You can use a hammer. All right. So this now is a hammer. Okay. So you pronate and supinate. If it gets really easy, you start putting weights on the top of the hammer, and that makes it harder. Okay. So there's no, not. This is a hammer. All right. We're going to pretend it's a hammer. All right. Because it has nails. Got it. All right. It's this that's going pronate, supinate, back and forth. Not your arm going this way. It's here. So, most often seen in tennis backhand caused by repetitive microtraumas to the insertion of the extensor tendon or the extensor muscle of the lateral epicondyle. It gradually comes on and then it gets worse. Matter of fact, they've got a little thing in tennis that they put on their racket to help absorb the shock from hitting the ball. Just a little button that goes in the strings. So that way it doesn't go all the way, that shock doesn't go all the way up your arm. Go to Academy, you'll see one. All right, we talked about how to treat it. Include rice, non-steroidal, anti-inflammatory drugs, analgesics, which are pain relievers. All right, range of motion exercises, progressive resistance exercises, deep friction massage, which is going back and forth across it, and hand grasping and supination, and avoid pronation movement. You can wear a neoprene sleeve for 2 or 3 months. We talked about that. So you'll have to just go from one to the other. How about a dislocation? Anybody ever seen a dislocated elbow?
Right here? No.
Spades, you ever see a dislocated elbow? Football? So, yeah. No, absolutely not. Look, where's the arm? See those yellow things? That's a whole lot of nerves. Let's say that you put it in place and this somehow gets trapped underneath something, you're in trouble. Not only do you have that, but what else is going to be going through here? You've got nerves, and you also have
First up.
blood supply. You trap one of those. You trap an artery, or you ruin the blood supply going from here to here, and pretty soon they're going to be called lefty because they won't have righty. Okay, you know, yeah, it's not.
Yeah.
Best thing to do is check for a pulse. All right, look for capillary refill. Ask if they can feel you squeezing. If you're squeezing their fingers, ask if you can feel that. That doesn't work. Take a something sharp, poke them in the finger so they can feel it, or on the back of the hand. And if they've got all that, they're good. Pack them and rack them. Get them out of there. Put them in a splint. Take a vacuum splint. Put it around them in the position you find them. All right, and off they go to the hospital. An orthopedist is going to take an X-ray before they reduce it. Okay, so caused often by a fall on an outstretched arm when it's hyperextended or a severe twist while it's in a flexed position. It's not hidden. Golly, no telling how many years. I've seen one dislocated elbow. 20 years ago on a football field with my eyes. All right. It involves rupturing or tearing of most of the stabilizing ligamentous tissue, and it's going to have quite a bit of hemorrhage and swelling. There is absolutely severe pain and disability. They will be seeing, they'll be having tears. Nerve and blood supplies may be disrupted, which is the big reason why you've got to make sure that you're not sitting there trying to reduce it. So, here is a dislocated elbow. All right?
That's the right arm. What is the
Yeah.
arm?
Um,
That's not a K. What is that?
M, medial right.
Oh.
Oh, I just love your lights go on. Ding! Oh. Here's one without an X-ray.
It looks like an ankle.
Yeah, well, it looks like looks like he's got a heel bone now. Well, yeah, elbows aren't supposed to look that way. And in the back, you're going to see a huge depression here. All right. So as the skin wraps around that part that's now been voided. All right. Injuries. All right. Treat by applying cold and pressure immediately. A sling. I certainly would tell you put them in a vacuum immobilizer, a Kramer splint bag, and refer to a physician for never reduce a dislocated elbow. Always have the doctor do that. They're going to take pictures. You might have it to where there's a fracture that needs to be lined up. You try and do that, and you get that fracture site screwed up. Now they're in for surgery, and you're the one that very well could get blamed, even though you're trying to help. All right. Once healing has occurred, use heat, passive range of motion. Strenuous exercise needs to be avoided. There's another couple of dislocated elbows. Aren't they pretty? Look at that. You guys already finished a whole chapter today. So tomorrow I need you to know the listening question, which is, what are the bones of the elbow? All right? And then we'll review. And you want your test on Monday? You have all weekend to study.